Our next patient is a 68-year-old female. She has no family history of breast cancer, and she presented with bloody nipple discharge on the right. So here's her mammogram, and she has a sort of a dense breast tissue, and as we often see with nipple discharge, we typically don't see a whole lot of findings on the mammogram. Once in a while we may see a dilated duct or perhaps some other abnormality, but typically not a whole lot of findings. And here's her medial lateral obliques. Again, nothing real significant on the right in the area of the nipple discharge. So we did an ultrasound, didn't find anything, and because she was symptomatic, we ended up sending her for duct excision, and she had a papilloma that was removed. The discharge resolved, thankfully, and so then she came in for her annual mammogram. She had no new concerns, no nipple discharge, nothing else significant. So here's her mammogram the next year after her excision. And you can see on the right, they did mark with a skin marker her scar and her medial lateral obliques. And you see a little bit of distortion, not very significant because it was, just right behind the nipple, but a little bit of distortion there. So new calcifications were seen in the right breast. So here's the area of calcifications which we're seeing. And on the CC, they look like they correspond to the area near her surgical scar. And so, we've all certainly seen new calcifications that pop up after surgeries, particularly after radiation. You can get those fat necrosis calcifications. Now, she clearly didn't have radiation because it was just a papilloma, but we were thinking, could it be related to her surgery? So here it is on her medial lateral oblique. And here you can see that it's not near her scar. I mean, it's near, but it's superior to her surgical scar. So it's doesn't correlate directly to the area where her scar was. So we did some magnification views. And again, you can see on the craniocaudal projection, they do overlie right where the surgical scar is. And on the medial lateral oblique, you can see it does not correspond. They are much higher than the surgical scar. So they are not in the vicinity of where her duct excision occurred. So we were concerned, obviously, because we did not feel that these were related to her surgery. So we decided to proceed for a stereotactic guided biopsy. So stereotactic guided biopsy was performed on this patient. And we did retrieve the calcifications. There were just a few of them, actually, because again, in 1 year's time, there weren't very many that formed, but we were able to retrieve them. And here is her post-biopsy mammogram. And the pathology came back as ductal carcinoma in situ. So then she went on to have a seed localization performed. And here's the seed localization. You can see the radioactive seed is right near the biopsy clip. And of course, we'd all love those to be the case in every example. And, certainly sometimes the seeds don't go exactly where we want. But in this case, thankfully it did. And here's the specimen radiograph showing a few residual calcifications, the biopsy clip, and the radioactive seed. So again, I think it's important, just to summarize that case, is that you really need to make sure that, again, if you're calling something from surgical scarring, that it does correlate in both instances on both images.